So I'd like to introduce our speaker today, and Dr. Fernando Dip is from Cleveland Clinic Weston. He's going to be talking to us today about intraoperative incisionless fluorescent cholangiography, a new standard in surgery of the biliary tract. So Dr. Dip, thank you very much, and please go ahead with your presentation.
Good morning, everyone. First of all, I would like to thank Dr. Wexner and Dr. Rosenthal for giving me the opportunity to present and show you what we have done here in Cleveland Clinic, Florida this year with Dr. Rosenthal, also Sinfendorfer, Samuel Samstein, and Dr. Lomenzo. So what I'm going to present today is something new that we really believe that can change the way how we operate. And first of all, I would like to divide my presentation in three parts. The first one is what is the problem of laparoscopic cholecystectomy today and in 2013, and why we really believe this is going to be a good method. What method we have to resolve the problem we have with the laparoscopic cholecystectomy, and which is the real role we have today with the fluorescent cholangiography. If we look at the history, the first open cholecystectomy was performed and was described by Karl Langebuch in 1882. And 100 years later, the first laparoscopic cholecystectomy was described by Eric Muhe and was very different as what we see today with the high definition systems. And it became really, and very soon, as a standard of care. And the reasons are because the less hospital stay, the less postoperative pain, less convalescence time, and better cosmesis. But of course, as a minimal invasive approach, we have disadvantages. And one of them are the learning curve. Nowadays, in the residency, we learn how to do a laparoscopic approach. But before, it was more difficult. Bleeding, and bleeding is one of the most important causes of conversions, and postoperative hernias. But one of the most important problems we have today, and we need to discuss, is what is happening with the bile duct injuries. We know that the laparoscopic cholecystectomy today are one of the most common procedures performed worldwide. And only in the United States, there are more than 750,000 of laparoscopic cholecystectomy, and with a rate of bile duct injuries on 0.4%. So more than 3,000 patients will suffer a bile duct injury every year. And if we look at the numbers in the literature, we have rates that are from 0.25% to 0.55%. But the real things and the real life is that it is underestimated. And there are papers that describe also 1% of injuries like, and consequences like bile leaks. And which are the consequences of having a bile duct injury? Multiple interventions for the patients, morbidity, mortality, stenosis after the repair of the bile duct injury, in some cases liver transplant, and nowadays something that is very important for us, the cost and litigation. Once a patient had a bile duct injury, it starts a very hard way with CT scans, MRIs, catheters, and open surgeries that complicate really the life. And what is happening with the litigation? The bile duct injury was the most frequent injury resulting in litigations in the recent years. And 65% of the cases favor claimants, and with the total cost of $33 million a year. We can think that the bile duct injuries occur with non-trained surgeons or in acute cholecystitis in the urgency. But the real is that in 72% of the injuries occur in elective cases. So which are the reasons? The learning curve, lack of tactile feedback, we lost this with the laparoscopic approach, 2 dimensions and visual perception, and the anatomic variability. If we see this paper describing the United Kingdom, every year we have more laparoscopic cholecystectomy that are performed, but the rate of injury is always the same for 4% of the cases. Visual perception. We think that we are seeing or watching a structure, and the thing is that we are identifying another one. In 97% of the cases, the visual perception is involved in a mistake or in the bile duct injury, and only 3% is a technical problem. What is happening with the variability of the anatomy? In a study of 513 cholangiograms, we see near of 20% of aberration in bile ducts. And if we see this picture is very known, we know that we have long cystic duct, short cystic duct that are behind the bile ducts, so it makes it more complicated. So what do we have today to resolve this problem? Two things that are very known in the world: critical view approach of safety and intraoperative cholangiography. The critical view approach of safety, we know that it is the complete dissection of the Calot's triangle with the identification of the cystic duct, the cystic artery. But there are papers published that talk about that even though with the critical view approach of safety, the number of bile duct lesions is the same. And the same Strasberg described in the Journal American College of Surgeons in 2010, that there's no level 1 type of evidence that the really critical view approach of safety really reduce the bile duct injuries. And one of the reasons described in this paper is because not everybody does it. What is happening with the intraoperative cholangiography, described by Pablo Mirisi in Argentina? We know that the cholangiography, intraoperative cholangiography, it's very useful to identify early a complication, but it cannot avoid it. There is no benefit in detecting common bile duct stones nowadays. Intraoperative cholangiography added a mean of 16 minutes on the total time in surgeries, and so there is no robust evidence to support or abandon the use of intraoperative cholangiography to prevent a bile duct injury. We really believe that we have to do it systematically, but it doesn't avoid an injury, it avoids more complicated bile duct injury. And with intraoperative cholangiography, there are papers established that in 37,000 patients, the rate of the injury was the same. And this is what happened in real life. Now, near 20% of the surgeons really does the intraoperative cholangiography because they don't have C-arms, X-ray, or because of the cost or because of the time. So do we have here a new surgical revolution? We need, first of all, to answer these questions done by Gerald Fried. Can this innovation we are going to present fulfill a clinical need, add this value to the existing options we have? It's beneficial, be financially viable, be adopted by the average surgeon with relative ease. So the technique we are going to present uses fluorescence, and the fluorescence is the emission of light by the substance that has absorbed light of another electromagnetic radiation. And that means we have an infrared light, we have a wavelength, and we expose a dye with this wavelength, and then we become another one. This is not a new idea. This was published in 2001 when the group of Hoffman started to see that there was a way to see the bile ducts with fluorescence. After that, Figueredo continued the works, and now we are working with a dye, indocyanine green. So the indocyanine green has a couple of advantages that are very interesting. It has a liver excretion, it has a low cost, it is a safe drug. The complication rate of the side effects starts at 0.5 milligram kilograms, and the complications start at 0.03%. So it's very low, and the dose we use is 0.05 milligram kilogram. The drug is old. It was approved by the FDA in 1959, and it was used before for hepatic function to test the hepatic function, to evaluate the cardiac output, the renal perfusion, and in 1880, it was used to see the fluorescent angiography. So the procedure starts with administration, intravenously administration of the ICG, indocyanine green, before the surgery, in a dose of 0.05 milligram kilogram. So we have time, 1 hour before the surgery, so we have time that the liver excrete the indocyanine green. Then the procedure starts as usual with the collocation of 4 ports in the abdominal cavity. Then the calot triangle is exposed by the xenon light, the white light. And when we want to visualize or identify better the structures, the biliary structure, we press or we push a pedal, and then we change the light to an infrared light. And by pushing the pedal or pressing the pedal, we activate the fluorescence system, and we activate also filters that are in the scope, and we can visualize the structure that we can see there. The first papers published were by the group of Ishizawa and Kokudo. They started to evaluate with indocyanine green and fluorescence the hepatic segment, the liver segments, and they identify also in 13 cases the bile duct, the extrahepatic bile ducts. After that, a group of Aoki and Otsuka identify 90% of the cases, the liver segments, and the extrahepatic bile ducts in 70% of the cases. And the same group of Ishizawa then studied the extrahepatic bile ducts and they saw the structure in 100% of the cases. The system, when we illuminate the abdominal cavity with xenon light, we are in a range and a wavelength of 600 and 700. But when we change the light to an infrared light, we change the wavelength to 780 nanometers. And after the activation of the system, we receive a wavelength of 830, and we cannot visualize the structure with the naked eye, so we need a filter. And it is activated, as I said before, and we can get this kind of images. So everything that has ICG, so the bile ducts and the liver, are going to emit fluorescence, and everything that we are going to see black is our vessels. The equipment is very simple, as a usual laparoscope with a filter inside and a pedal that activates the system. These are cases we have performed. In some cases, this is an easy case, but we can see very well the cystic duct and the extrahepatic bile duct in fluorescence. In easy cases, it's also very useful for teaching because the visualization, the control the surgeon has to the resin is much better. This is another case. We can see the extrahepatic anatomy with a parallel cystic duct that otherwise we cannot identify with a xenon light. And even though these are easy cases, we know exactly where to start the dissection, and we can avoid then bleeding. If we open there the calot triangle and we change the light, then we're going to find the direction of the cystic duct and the position of the main bile duct. We have there the union between the cystic duct and the main bile duct. And in this case, not in all cases, but in a couple of them, in which the bifurcation, the extrahepatic ducts bifurcation are low, we can see even though the hepatic ducts. In this case, also, we evaluate the cystic artery that is in front of the cystic duct. As it has no indocyanine green, we see it on black. I need to apologize myself because of the images, because they are not high definition, but the images we get in the OR are much better. What we do in some cases that we cannot identify the cystic duct, what we press the common bile duct, so we have a reflux maneuver, and we can identify the entrance of the ICG in the cystic duct and in the gallbladder, and this is a better way to evaluate where really the cystic duct is. The penetration of the infrared light is described as 1 centimeter, but it's not only how depth can the infrared light penetrate, also it's important the quality of the tissue we have. And in some cases, in more or less 8% of the cases, we can see, as in each case, the accessory ducts. So we analyze also why to do this method, and we identify 10 clear reasons. What's happened with the complexity? It's very easy to use. We only need to administrate the indocyanine green 1 hour before surgery. We have administrating the ICG 20 minutes before surgery, and it works also. And to activate the system is very easy by using a pedal. Real-time surgery, when we change the light, we can also move the instrument. This is not something that we need for dissection, but it is safe because we can see the tips of the instruments. Teaching tool. It is, even in difficult cases, it was easier for residents to understand the anatomy. Learning curve, it is easy to understand because, and it's not invasive, no cannulation is needed, and easy identification of the images from the beginning. Safety, and we are talking about that, safety. Indocyanine green has a low cost and very few side effects. The infrared light is not harm for the patients, and is not an invasive method. The usefulness, this is a paper is going to be published, and what we see here is over 100 patients, we see more than 80% of the cases, the extrahepatic bile ducts. And we compare also what's happening with in cholelithiasis, in acute cholecystitis, or in chronic cholecystitis, before and after dissection. Of course, in some cases, we need to remove the fat, but we don't need a complete dissection, of course, to use the method. There's no much difference between chronic cholecystitis and acute cholecystitis. And what's happening with the time? What we evaluate the time to use an intraoperative cholangiography, we need more than 7 minutes in average. And for fluorescent cholangiography, we need less than 1 minute because we can use it several times, and the method requires only a few seconds. And this is very important, what's happening with cost. When we evaluate which is the cost of an intraoperative cholangiography in Cleveland Clinic, Florida, we have that in average is $750 per procedure, and in fluorescent cholangiography it requires only $15. Avoid X-ray exposure. We can use it also in pregnant women, or in special medical conditions, like in obese patients, where the C-arm doesn't fit. Which are the limitations yet? The light penetration or visualization of stones. So to conclude, we believe that intraoperative fluorescent cholangiography is an additional tool found in the armamentarium of a laparoscopic surgeon. It is recommended that intraoperative fluorescent cholangiography is routinely used in laparoscopic cholecystectomy since it has proven to be safe, feasible, fast, and cheap. Moreover, it removes radiation exposure, allows the direct recognition of biliary anatomy, has no adverse reactions, and requires no learning curve. Most importantly, it can be used in real-time surgery and guides the surgeon during dissection, transection, and resection around the biliary anatomy. We don't believe that this is going to replace the intraoperative cholangiography, but it is another tool we now have. So thank you very much.
Thank you very much, Dr. Dip. Thanks for a great presentation and for doing the work in this interesting area. I'll remind the audience that there's a number and an email on the screen that you can contact Course Call and get in your questions or comments as we proceed with the discussion. I'd like to first start with going to IRCAD in Strasbourg, France, and just ask a general question. Are you using this technology, and if so, where do you find this useful, and do you find that it will find its place within general surgery, whether it's biliary surgery or other abdominal surgery procedures?
Good morning. I'm Michele Diana from Strasbourg. Yes, we are using a similar setting as the one shown by Fernando Dip. We use the Light P from Karl Sturz, which I guess was exactly the same he showed, and we use it for both biliary anatomy assessment and for perfusion evaluation of the anastomotic site. I would like to ask to Fernando if you could answer me, because we are a little bit struggling on the injection time of the dye, because he said he normally does injects 1 hour before procedure. Within that 1 hour before could influence the readability of the images, because the liver after 1 hour gets really, it stocks too much dye, and after 1 hour is very bright, and it can prevent for a nice detection of the biliary anatomy. And this problem is even more evident with the robotic, the Firefly, which is integrated into the Da Vinci, which is more sensitive than the Light P, for example. And 1 hour later, your liver is really too much bright to allow you any interpretation. Could you comment on that, Fernando?
Thank you, Diana. It's nice to hear you, and we wait you and the New Frontiers in the FORGATS meeting next year. And what I believe is that it's true that if you administrate intravenously the dye 1 hour before the surgery, we are going to have a lot of fluorescence in the liver. But I see this as an advantage also, because if you have a lot of light in the liver, then when you change the light, you're going to see better the instruments. If you have only the dye in the common bile ducts, you're going to, for sure, identify better the bile ducts with fluorescence. But then your instruments are going to be black, and the rest of the abdominal cavity is going to be black. So we're talking about safety, and safety is not only to see the bile ducts. If you change the light and you see the whole abdominal cavity black and only see a light in the common bile duct, and you cannot see the instrument, then you're going to have a problem. So our light comes from the liver and also from the bile ducts.
Great. Thanks for those question and your comments. We have a question from Virginia Commonwealth University. If we can go to that site.
The question is that the main reason for doing an intraoperative cholangiogram is to detect common duct stones. What is the sensitivity, false negative and false positive, for detecting common bile duct stones with this technique, please?
Yes, thank you for the question. And the thing is, we haven't seen with this technique common bile duct stones. But the question I have and the answer I have is we don't use this to see or to identify common bile duct stones. The purpose of this study and the purpose of these methods is to identify the common bile duct and the cystic duct before cutting it. And once we have cut a duct with to perform also the intraoperative cholangiography, then the mistake could be done. And I'm not against, of course I'm not against the intraoperative cholangiography. I believe really it's very useful and it's very important to use it and to use it systematically, also to identify the common bile duct stone and to evaluate if we have done a mistake or not. The main of this study is to identify before cutting. That's why we name it Incisionless.
Great. So let's move to Imperial College in London. I'd like to get some thoughts from our colleagues in London. And again, ask the question, is this technology that you're using, whether you're using it in biliary anatomy or otherwise? Do we have some colleagues there that can make any comments?
Hi, good morning. We're a group of registrars, resident trainees. Unfortunately, none of us have any experience in this technique. The majority of UK surgeons remain using intraoperative cholangiograms on a selective basis. But this sounds very interesting, so very interesting presentation. Thank you.
Oh, very good. Thanks for joining us. I actually have a follow-up question back to IRCAD. You had mentioned that you use this to look at the perfusion of your anastomosis. Can you elaborate on that a little bit for us and maybe talk about other applications for this technology in the GI tract?
This is Blair Worm from Carolinas Medical Center. There's actually two applications we've been using this often on. One is we do a lot of complex ventral hernia repairs with large paniculectomies, advancement flaps, and prior to closure, after the mesh is placed, a lot of times we'll use this the same imaging style, the indocyanine green fluorescence angiography, to look at the perfusion of the flaps to see if there's anything that can be trimmed to avoid breakdown of the abdominal wall. The other thing we're using it for is when we do esophagectomies, the site of the anastomosis, prior to placing the conduit up into the chest.
Thanks. So now what sort of criteria are you using? If you're looking at anastomosis, what is it very subjective in terms of whether you think it's lighting up, or is there some objective findings you can hang your hat on to decide whether that's an anastomosis that's going to survive or not?
Well, there's two different ways you can use the software. Essentially, you can use it with the grayscale or color imaging, and you can also use it either like an absolute value, or you can use it as a relative value. When you use the relative value, that means you're picking somewhere else on the screen as your 100% mark of most perfusion, and everywhere else is less. So the areas that are darker or dark blue, or less than 20%, at least in the esophagectomy patients, we've seen that as patients with low perfusion in one of the series that we just had at American College of Surgeons. For the abdominal wall stuff that we do, we actually use the absolute values, and we looked at a few different levels of absolute values, whether it was 5, 10, or 15 absolute values, and that's on a scale of 155 shades of gray. When it was less than 10, that contour actually had the highest sensitivity, greater than 90% of detecting an area that would break down and necrose an abdominal wall.
That's great. That's a great application for the technology. Thanks so much. How about Mount Sinai? Is Mount Sinai online with us this morning to hear if there's any colorectal applications for this technology? So
Morning. Well, it's such an interesting technology, and it seems so intuitive that, why wouldn't you use this? But I guess my question is, if the rate of common bile duct injuries that we're seeing is 0.2 to 0.5%, I mean, we usually say 0.4% when we're talking to patients, what kind of study are we going to need to do to demonstrate that this is going to result in a decrease in common bile duct injuries? I mean, it would have to be a massive randomized prospective trial. I'm no statistician, but I'm guessing it would be 5,000 patients. Is it feasible to do this type of study, and are we ever going to be able to, to get real solid evidence to show that this is going to improve our outcomes? That's ultimately what we're trying to do.
It's a great question. Dr. Dip, can you comment on that, please?
Yeah. Okay. We have started with this technology 3 years ago. This year we were working here in Cleveland Clinic with the group I mentioned before. I really believe we should do a multi-center study to really evaluate the decrease of the rate of common bile duct injury. We need a lot of patients to determine the effectiveness of this kind of technique. But what I believe also is there are a lot of surgeons around the world that don't use any kind of technology, IOC, or even they don't do a critical view approach of safety. And if we give everybody a technology that can identify the structures, and it is very easy to do, and it is very cheap to do. So why don't to start doing it, and that's what will happen. Maybe the answer of Mount Sinai, we are going to have it in 5 years or in 10 years.
Thanks, Fernando. I have a quick follow-up question for you as well. One of the limitations that you mentioned of the technology is the light penetration. And so many of our patients are obese with a large amount of fat in the hepatocystic triangle. In addition, they have very large fatty livers. What information can you tell us about the use of this technology in those really big fatty livers with a lot of fat within the portal triad?
I believe it is also useful because anyways, you have to dissect the calloid triangle. And what happened in some cases with, for example, this acute cholecystitis with the epipleon and everything there, and we need to dissect. Of course, if you change or activate the system, you are not going to be able to see nothing at the beginning of the story. But the thing is, when you start dissecting and you start to see the light, you're not going to see everything, the whole extrahepatic bile ducts. But if you start to see the light, then you have a guide to start dissecting. And there are a lot of cases that you start dissecting and you really don't know where the bile ducts are. So if you have something there, in an obese patient, in a fatty patient that you identify where at least something is structured, and you are sure that this is the bile structure, then it's easy to start dissecting.
Is there any evidence at this point in terms of uptake or delay time for the fatty liver patients, the very large fatty livers? Does that alter the uptake of the ICG?
No, I don't have yet.
Okay, it'd be an interesting thing to look at, I think, because so many of our patients are heavy, and the timing, as was mentioned earlier, may be an important part of identifying the anatomy. We have a follow-up question from Carolinas. We'll jump back to Carolinas Medical Center.
Morning, guys. So this is John Martini. I want to get back to the, how useful this is. I'm a big fan of technology, and I think this is interesting stuff. I was asked to review a paper last year looking at a single institution series of use of this technology, and the sensitivity at that institution was like in the 60 to 70% range of just identification of the cystic duct, common duct anatomy. So, I mean, what are your thoughts on are the systems going to get better, or I mean, if you have if you only have a 60 or 70% sensitivity of identification, what's your thoughts on, is this really going to keep people out of trouble for the difficult gallbladders? Because the easy gallbladders, it's nice to see the anatomy, but you don't need it, and it's the hard, thick, inflamed porta hepatis that are you going to be able to see anything? So can you give me your thoughts on that, Fernando?
Yes, what I believe is that it depends on the quality of the light, it depends on the quality of the camera, and I believe that this is something that is just starting. And next week, for example, we are going to try on lab another camera, and we are going to see better the instruments inside the abdominal cavity. So I believe this is going to improve, and it depends for sure of the camera you're using and the scope you're using and the light source. I believe this is like the laparoscopy 20 years ago or 15 years ago. We could see everything in a screen, and now we have 2 screens in the OR with high definition. It's going to change, and it's going to improve.
Thanks, Fernando. Let's jump to McGill University, see if there's anybody there who might have some comments.
Good morning. Many thanks for the presentation. I'm the fellow at McGill University. I actually used this technology in Holland when I was working there on an elective a couple of years ago, and my question was also just relating to the usefulness, because at the time we had to switch the images, of course, and you guys have been talking about visualization, of course, and the main concern I had when I was using it a couple of years ago was you're doing the dissection under one view, and then you're looking at the bile duct and cystic duct under a different view. And so I don't know if there's any technologies that superimpose the images. That's really the only question that I had. I'm sure that would be something in the future. But otherwise, very much enjoyed the talk. Thank you very much. We are not using it at McGill, however.
Great. Thanks for your question. Fernando, maybe you could answer the question in terms of what's ahead here for this technology, and specifically those kinds of technologies, but where do you see this moving forward? And then we'll wrap up.
Yeah, well, there is a system that you can see the both images together. You don't need to change the light, but in my impression of that is that when you have the both images together, you don't have and this is my impression, you don't have a good quality of fluorescence. So that's why I believe this is going to improve, and in the future we are going to see fluorescence, but also we're going to see the light in the abdominal cavity. So you are going to be able to move the instrument or to dissect with fluorescence. The thing is, you can go back and forth as many times as you want, and there's you're not blind when you are with fluorescence.
Great. Well, I think with that we'll probably wrap it up. I think it's around 7:30 here. I'd like to thank all the sites for their participation and a great discussion. Congratulations to Fernando for your work and for your presentation.